continuing with the management of hernia, and continuation is from the previous lecture. In the previous lecture, we talked about the general principle of hernia management and also the tissue repair, that is bassinis and soleus repair and hernioplasty, mesh repair. So, those general principles, they are the same, and there are other options for the surgery we discuss today, and those principles we just revise. For any hernia, we have to first open the subcutaneous tissues, dissect out the sac, reduce the content, close the sac and do something to repair the or augment the strength of the wall. So, these are the principles that is applicable with all the hernia repairs. In the previous lecture, we discussed about the two surgeries for the tissue repair. One was the bassinis, other was the soleus. This is the third one. This is also a tissue repair, McVay repair. In this, uninterrupted non-absorbable sutures are placed to approximate the edge of transversus abdominis with the Cooper's ligament. On the medial side and laterally, the transversus abdominis aponeurosis is approximated to the iliopubic tract. You know, iliopubic tract is a thickening in the fascia transversalis, that is parallel to the inguinal ligament. So, this is kind of a tissue repair, and it is indicated in direct inguinal hernias, large indirect inguinal hernias, recurrent hernias, and it is particularly suited for the strangulated femoral hernias. Strangulated means when we cannot place a mesh. So, if there is a femoral hernia where we cannot place a mesh, then this McVay repair is well suited for that. Because we are pulling this transversus abdominis below, so there will be tension in the suture line and that may lead to the recurrence. So, to avoid that tension, we need to put a relaxing incision into the external oblique fascia. So, if we transect this fascia above it, so it will loosen and come easily downward. So, this is the McVay repair. It is a tissue repair in which this transversus abdominis aponeurosis is approximated to the Cooper's ligament. Other is the plug and patch repair. Plug and patch repair, as you can see, it is a hernioplasty. It uses mesh and a cone shaped plug of the proline mesh is placed into the internal ring. So, you make a plug and put it in the defect of the internal ring, and then we place a mesh over it, patch of mesh over it. So, this is called plug and patch repair. It is a modification of the Lichtenstein hernia repair. So, if you do not put that plug, then it becomes a simple like a Lichtenstein hernia repair that we discussed in the last lecture. In Lichtenstein hernia repair, that is a tension free repair, a mesh is placed between the internal oblique and external oblique and lower edge is secured to the inguinal ligament. And in plug and patch, we simply place a plug of the proline into the defect of the posterior wall. Third one is the Stupa ribs repair. Till now, all the repairs, whether it is tissue repair or mesh repair, they were done anterior to the posterior wall. So, we did something to strengthen the posterior wall anterior to it. So, we can do something posterior to it also. Understanding this repair is very important, because it is a totally different from what we have learned till now. Just repeating the same sagittal picture. This is the external oblique fascia. It is turning inward to become the inguinal ligament. This is the cord structures. Then comes the internal oblique. This is internal oblique and transversus abdominis. Then comes the fascia transversalis. Fascia transversalis, it lines over the inner aspect of these muscles, and it is complete, and it makes the posterior wall. And this is fascia transversalis. Till now, we have learned that all the repairs are done before to it or anterior to it, and either we place a mesh or suture these structures to the inguinal ligament, that is tissue repairs or mesh repair. But if you go deeper to the fascia transversalis, there will be periperitoneal fat, and this then will be a line of peritoneum. So, this is the peritoneal cavity, and this is peritoneum. So, this is the complete abdominal wall: peritoneum, periperitoneal fat, fascia transversalis, and other structures. Till now, we are opening from the front and repairing here, but we know that this any hernia occurs because there is a weakness into the posterior wall. So, this peritoneum comes invaginates outside. So, this is how this hernia occurs, but we cut it here and we repair it, but we do not do anything here till now. So, what we can do, this is a totally different approach, periperitoneal approach of repair. This is the fascia transversalis and this is this. So, we can do something, somehow we reach into the fascia, this periperitoneal area, either making an incision from this side, we make an incision here and go into the fascia this periperitoneal space, or we make a go into the peritoneal cavity and then reach to the periperitoneal fat. Then we can reduce the content, manage the sac, and place a mesh into the periperitoneal fat between the fascia transversalis and peritoneum, and then again it will keep hold the sac inside. Nothing will come out because it has covered, but the only thing that this mesh is placed between the fascia transversalis and periperitoneum. Till now, we are doing from the anterior, not going beyond the fascia transversalis. Now, we are in beyond the fascia transversalis, and we can place a mesh into the space between the fascia transversalis and peritoneum, that is periperitoneal space, and it will cover the openings. So, it will cover all the openings. So, this is the another, that was another way of doing the repairs. So, if we do it in the open technique going through the abdominal wall, we call it Stupa techniques. Here a large mesh is placed between the preperitoneal space. As you can see in the picture, this is the dotted line is a mesh. So, a large mesh is placed it between the fascia transversalis and peritoneum. And here comes the concept of this myopectoneal orifice. If we are doing the repair that we learned in the previous lecture, or you are only covering the site of the direct and indirect hernias. By this way, we can cover the all sites of including the femoral hernias, because femoral hernia will occur below the inguinal ligament, and the mesh can place a large mesh that covers the femoral hernia site also. So, it will cover all the hernia, potential hernia sites. So, it is better because it will cover all the potential hernia sites, and the concept of myopectoneal orifice, if you remember from the very first lecture, it comes into this picture here. If you don't remember, then we can go again revise that myopectoneal orifice, because that is an important concept. So, this is the myopectoneal orifice. So, there is potential hernia sites above the inguinal ligament and potential hernia sites below the inguinal ligament. And if you do repair like Lichtenstein or Bassinis, they repair only above the inguinal ligament, they do not do anything below the inguinal ligament, because if a person has developed one hernia, he is more likely to develop other hernias, because the weakness will be global. So, if you do something that covers all the potential hernia sites, that will prevent the recurrence and as well as the occurrence of a new hernia. So, this stoporifice is important because it covers all the potential hernia sites, and the mesh is placed in the preperitoneal space. We do not try to repair anteriorly, and the same thing is exploited in the laparoscopic hernia repair. Here we make a incision in here and then go to the preperitoneal space, and another technique is the sandwich technique. In its two meshes are placed, one is the posterior to fascia transversalis, another is anterior to it. So, it is like combining both the together. Okay. Then comes the laparoscopic hernia repair. Laparoscopic hernia repair is like performing the stoporifice with a laparoscope. Stoporifice we do in the open technique, make an incision in the abdominal wall, reach to the preperitoneal space and then perform the surgery. Here we use the laparoscope to minimize the incision. Laparoscopic hernia repair is a tension free repair. Tension free, if you are saying it, it means simply it is the mesh will be used and it will be placed in the preperitoneal space, and because the advantage is that we can place a large size of the mesh and covering all the potential sites of the hernia. It covers the myopectoneal orifice, and like if you place the mesh behind the abdominal wall, then any positive pressure will within the peritoneal cavity will keep the opposing the mesh against the opening. So, it uses the natural forces of the abdominal wall. It is more useful if in bilateral or recurrent hernias, and there are three approaches. The names are varies how we approach is the totally extraperitoneal, transabdominal, preperitoneal and intraperitoneal onlay mesh. So, first we understand what these three terms are. again going through it. Somewhere there will be umbilicus, and this is the peritoneum, this is the periperitoneal space. So, if we place a trocar or our laparoscope through the abdominal wall into the periperitoneal space only, we do not enter into the peritoneal cavity, and we perform the surgery from here, then it is called total extraperitoneal, because we are not in within the peritoneum, we are outside the peritoneal cavity. So, it is total extraperitoneal, that is TEP. But what we can do? We can go within the peritoneal cavity and then open the peritoneum and then perform the surgery and close the peritoneum. So, it is because it is transabdominal preperitoneal repair. So, this procedure is called TAPP, transabdominal preperitoneal. We are going within the peritoneal cavity, opening the peritoneum and then repairing it. Other one was the total extraperitoneal. Another way of placing the mesh is that this is the peritoneum. In Liechtenstein, we place the mesh within the external oblique and internal oblique. In Stoparives or in these two, we place the mesh within the this periperitoneal space. We can place the mesh in the peritoneal cavity itself, just just below the peritoneal, this peritoneum. So, we can place a mesh below the reduce the content, because the defect will be like this only. This is the peritoneum that is going through. So, we can reduce everything and place a mesh within the peritoneal cavity against the peritoneum. So, this become IPOM, intraperitoneal onlay mesh repair. So, these are three ways by which we can place the mesh. One is the Liechtenstein, that is through anterior approach between the external oblique, internal oblique. Other is in the preperitoneal space, and third one is the in the peritoneal cavity itself against the peritoneum. But we often do not do IPOM, because if you remember the discussion about the mesh. Mesh is a polypropylene mesh. It is a prosthetic material that leads to the adhesion formation. If you place it within the peritoneal cavity, a small bowel will get adhered to it and will lead to erosion and fistula formation. So, this simple mesh that we place within the abdominal wall cannot be placed within the peritoneal cavity. We need a different kind of the mesh, and those different kind of meshes, they are very costly. This mesh comes around 1500 rupees, 2000, and they come with 35,000, 40,000. So, there is a huge difference in the price. So, this is why we do not go for that IPOM so often, but it can be done only with that we need a special kind of the mesh. So, this is about the laparoscopic hernia repair, the approaches and types of it. There are advantages of laparoscopic surgeries, and they apply here also. Because the incision is smaller in size, so recovery is quick, pain is less. Laparoscope uses camera that can magnify the tissues. So, it leads to the better visualization of the anatomy, and because it uses the principle of Stoparives, it places the mesh, large size of the mesh in the periperitoneal cavity. So, it will fix all the inguinal hernia sites, and there is a decreased surgical site infection because of the smaller incision site. But the drawbacks of the laparoscopic hernia repairs are like it is a technically challenged, requires more time, there is more risk of recurrence, and the cost is obviously will be higher. So, the laparoscopic hernia, although seems it will be less recurrence, but somehow it has got more recurrence rate. So, till now we have learned the anatomy that we see from the front. This is the anatomy that we see from through the peritoneal cavity. There are usually three folds: median umbilical fold that has allantois into it, urachus into it, median umbilical fold. Other one is the medial umbilical fold and lateral. Medial umbilical fold is formed by the obliterated part of the fetal umbilical arteries, and lateral folds are by the inferior epigastric arteries. So, these are the three folds, and this is the lateral. So, direct hernias occur medial to it, lateral occurs indirect inguinal hernias. And two more important things occur in this area. There are two triangles, like in open we will discuss about two areas, Hasselbalch triangle and myopectoneal orifice. At least remember these two triangles here. One is the triangle of Doom, it is laterally by the gonadal vessels, medially by the vas deferens with its apex at the internal ring, and inferiorly by the interface between dissected and non-dissected peritoneum. So, it will be here, this area, and this is the deep ring, lateral is the gonadal vessels and medially is the vas deferens. So, it is called Doom because there are blood vessels, you can see the iliac arteries, iliac vessels into it. So, this area contains iliac vessels. So, if you operate in this area, there may be injury to the large vessels, and so it is a condition like Doom. There will be so much of the bleeding. So, it contains iliac vessels and genital branch of the genitofemoral artery and femoral nerve. So, the content of this triangle and boundaries. It is called triangle of Doom because it can lead to the massive bleeding. Another area is the triangle of pain. It is lateral to this area. It is medial border is spermatic vessels, laterally is the reflected peritoneum, and inferiorly it is the iliopubic tract. So, this is called triangle of pain because it contains the so many nerves into it. So, if we use the electrocautery or in some other energy devices into it, it will lead to the injury to the nerves and pain. So, this is called triangle of pain. We also try to avoid this area. So, these are the two triangles and their boundaries and contents that we need to remember for the anatomy of the laparoscopic hernia repair. This contains lateral and femoral cutaneous nerves, femoral branch of genitofemoral nerve and femoral nerve. So, it is just simply lateral to other triangle. So, we discussed these three approaches for the laparoscopic repair. One was the TEP, it is like the stopper-ives, only the we enter into the first, see this is the TEP, we make an incision over the just below the umbilicus, dissect into the preperitoneal space, then we use a balloon like structure and we inflate the balloon into the preperitoneal space and it dissects the tissues, separates the tissues from each other, and then we deflate it and it creates a space there, and we can dissect the sac, reduce the content and close the sac and place a mesh into the preperitoneal space, a large size of the mesh. So, this is the total extraperitoneal repair. Other is the like any other laparoscopic surgery, we enter into the peritoneal cavity, create a pneumoperitoneum and then transect the peritoneum, make a flap of the peritoneum, enter into the preperitoneal space, just below it will be preperitoneal space, dissect into the preperitoneal space and then reduce the content and place the mesh in the same way as the TEP. So, it is only the approach is different, otherwise the things are the same. So, these are the two transabdominal preperitoneal approach, and other is the total extraperitoneal approach, and IPOM is we discuss later when we discuss the other incisional hernias, because they are more performed for the incisional hernias than the inguinal hernias. So, this was the all about the inguinal hernia repair. It is easier to understand if you understand the anatomy. It is just the manipulation of the anatomy that is done to repair the hernia. So, this is the list of the complications of the inguinal hernia. The more common is the urinary retention, UTI, architis, surgical site infection, pain. Pain is important because nerves passes through those areas and they can get entrapped into the mesh. We place the mesh into the areas where the singuloinguinal iliohypogastric nerves passes. So, they can be trapped into the mesh and cause the pain. Long term complications may be recurrence, chronic pain, and if you see the recurrence is nearly twice in the laparoscopic than in the open repair. So, that was about the inguinal hernias. Few words about the other kind of hernias. One is the femoral hernias. As the name suggests, it comes through the femoral canal. Femoral canal is bounded superiorly by the iliopubic tract and inguinal ligament, inferiorly by the Cooper's ligament, laterally the femoral veins, and medially the lacunar ligament. So, this is the medial boundary, lateral, superior and inferior. So, through this inguinal canal. What is the normal content of inguinal canal? It is the lymphatics. There is a lymph node here, there is a named lymph node in this area, lymph node of Cloquet. Okay. So, there are three things pass through: artery, vein and lymphatics in this area. So, this space is of the lymphatics, that is a nearly open space, the anything pressure, because it is simply lined medially and posteriorly by the peritoneum or fascia transversalis. So, it is a potential site for the femoral hernia formation. And femoral hernia appears below and lateral to the pubic tubercle, while the inguinal hernia is above and medial to the pubic tubercle. Because this is very tight space, it cannot, this neck is tight, there are bony structure or ligamentous structure all the ways. So, the neck is very narrow. So, it has high risk of complication. So, femoral hernias, they are at high risk of complication. So, any femoral hernia should be repaired immediately. We can wait in the inguinal hernias, but we cannot wait into the femoral hernias because of the high risk of complications. The differential diagnosis of the femoral hernias are like this. Most of the same things are the same as that of the inguinal hernias. Management of the femoral hernias, it is the similar principles are that you have to open it, reach up to the side, reduce the content, close the sac and repairs, do something to the augment the strength of the posterior wall. So, the only thing is the approaches are the different. If we go through the inguinal approach, that is like we do in the inguinal hernia repair, we can reach up to the fascia transversalis, open it and then reach into the periperitoneal space and kind of reduce the content and place a mesh there. So, it is the only approaches are the different. In high approach, we make the incision above the inguinal ligament, similar to like this stoporites. We reach into the periperitoneal space, reduce the content and close the sac and place a mesh into the periperitoneal space. And laparoscopic is the same, because again all the laparoscopic TEP and TAPP, they do the surgery into the periperitoneal space. So, the femoral hernias management is the placing a mesh into the periperitoneal space by different approaches. Other thing is different from the inguinal areas, other hernias are like Spezalian hernias. Spezalian hernias occur through this line, that line is called semilunar line. It is lateral at the lateral border of the rectus abdominis from the costal margin to the pubic symphysis. So, this is the semilunar line. Sometimes it may be weakened and because of the pressure the peritoneum may bulge out, make a sac between the different layers of the abdominal wall or into the subcutaneous tissues. So, the hernia occurs usually at these areas and this is called Spezalian hernias. And again the management is same, because it is a intraparietal hernia most of the time. So, we often need a CT scan to diagnose it, and it usually grows between the external and internal obliques. So, it is not necessarily will come out, it can enter into this space also. So, that was the Spezalian hernias. The principle is the same management of. Other is the ventral hernias, those inguinal hernias, and other than any hernia over the abdominal wall is called ventral hernias. It may be spontaneous or acquired, and epigastric hernias we call any hernia between the Gifford process up to the umbilicus is epigastric hernia, and then hernia can occur through the umbilicus or below the umbilicus. So, there is no supra or infraumbilical hernias, it is the epigastric or hypogastric hernias and umbilical hernias. So, these are the spontaneous hernias, they occur by themselves. Other is the ventral hernias, acquired ventral hernias, that is incisional hernias. Incisional hernia occurs at a point where there is a scar from the previous surgeries or trauma, and that leads to the weakness of the abdominal wall through which a hernia can occur. We call it incisional hernias. It occurs in around 15 to 20% of the abdominal surgeries. Incisional hernias are more common in women. Other risk factors for the incisional hernias are like obesity, elderly age group, male gender, sleep apneas, emphysema, wound infection, because wound infection will lead to the healing by secondary intention, and that leads to the weakened areas. So, different incisions has different incidence of hernia formation. Hernia is more common in the midline incision and it is less common into the lateral incisions, because into the midline there is only fascia and there is no blood vessels. Our blood vessel is very poor. So, simply you can see, if you make an incision in the midline, this fascia is less likely to heal than these muscles. So, midline incisions has higher incidence of hernia formation. When we want to repair the hernias, then abdominal wall hernias other than the inguinal hernia, then we encounter this anatomy. Okay, it is above the arcuate line, below the arcuate line. You might be remembering the arcuate line is something beyond which the posterior sheath is absent. So, these are the three flat muscles, their sheaths, and this is the anterior sheath of the rectus and this is the posterior sheath. The anterior rectus sheath is made by the sheath of the external oblique and part of the sheath of the internal oblique, and below it is formed by the part of the this internal oblique sheath divides into the two. Aponeurosis divides into two, half goes anteriorly, half the posteriorly. So, the posterior rectus sheath and anterior rectus sheath, but below the arcuate line there will be no posterior rectus sheath. So, all the three goes anterior to the it. So, if we place the mesh into this area, we will exploit this anatomy. So, the anatomy is important. This is the blood supply. The blood supply and the nerves, they travel into the space between the transversus abdominis and internal oblique. So, the area between the transversus abdominis and internal oblique, they contain the neurovascular bundles. So, one is the ventral hernia, is the umbilical hernia. Umbilical hernias may be congenital or acquired. Umbilicus is a ring within the linea alba, and if it is a congenital umbilical hernias, most of the time they close spontaneously by 2 years. So, every congenital inguinal hernia does not require surgery. If it persists beyond 5 years, only then it should be repaired, otherwise we can wait, it will resolve by its own. But if it is an acquired umbilical hernia or in the adults, it is more common in women, and if it is small asymptomatic hernia, then we can wait, and if it is large symptomatic hernia, then we need to repair, and repair can be done tissue repair or mesh placement. Tissue repair is called Mayow's repair. It is like double breasting. You can see the one edge is stitched to the posterior wall of posterior surface of the other edge, and then it is flapped. So, that it is like it was like this. So, we made an overlapping like this. So, it is called Mayow's repair, double breasting. But if the defect size is more, it is more than 3 centimeter, then we place the mesh. If it is less than 3 centimeter, then mesh is often do not required. We simply do a suture repair. And if it is the incisional hernias, then again the same thing, we dissect out the sac, reduce the content and close the sac and place a mesh. So, how can we place the mesh? There are different ways of placing the mesh. If you remember that placing the mesh in the peritoneal cavity, I use the word IPAM, onlay mesh repair. So, what this onlay is actually? So, we can place, because the mesh hernia is coming through this defect between these two recti. So, we can place the mesh between the two and closing the defect site only. So, this is called inlay mesh repair. So, placing the mesh within the defect. So, suppose this is the sheath on one side, this is the sheath on the other side, this is the defect. We can place the mesh between it. So, it will cover the it, this is called inlay, or we can place the mesh over the it, again it will cover. So, this is called onlay, or we can place the mesh below it and there will be plutonium over it. So, this is called underlay. So, there are different way of placing the mesh. So, this is the inlay, overlay, overlay is also called onlay, underlay, it is sometimes called sublay also. So, different names are used, underlay, sublay, overlay, or we can place into the peritoneal, this is the periperitoneal space, intraperitoneal. So, different ways of the meshes can be placed. So, this is the repair of the incisional hernias. Incisional hernias often we do only the mesh plasty, and we can do the IPAM also if we place a mesh within the peritoneal cavity. So, this was about the hernias. There are so many other things in the hernias, but these are the more important things that at least you should know, and you can read in detail from your textbooks, but these are the general principles of the placement of the mesh and the tissue repairs, and how we manipulate the anatomy, local anatomy to do the repair. Okay. So, this was all for today, and this is all for the hernias, and if you have any questions, doubts, you can ask today or any time, other time. Okay. About the clinical examination, you will be taught into the clinical classes. So, this was about the theories, something about the mesh and the repairs. Okay.